Hello, everyone. My name is Hazel, and together with my team, we are here to answer one question. How might street side medics improve their visibility amongst the homeless so that they are well informed of the free mobile healthcare service? Before we dive in, a quick introduction. On slides and presenting today are myself and Hong Tai. The presentation outline and content were developed by Burgesh, Kim Hugh, and Andrew. That said, all five of us contributed equally to the research, ideation, prototyping, and evaluation that underpins everything you are about to see. Streetside Medics is an Australian not-for-profit founded in 2020 in Sydney by Dr. Daniel Nair, the 2022 Young Australian of the Year. It provides free GP-led primary healthcare, and crucially, no Medicare card is required. SSM expanded to Melbourne in September 2024, operating across the CBD and St Kilda. The model is simple but powerful. It goes where people are, not where buildings are. The scale of the problem is significant. At the 2021 census, about 122,000 Australians were experiencing homelessness, including about 30,000 in Victoria alone. That is a 5.2% national increase since 2016. But here's the critical insight that shaped everything in this project. Streetside Medics Challenge is not surface capability, it's surface visibility. 90% of our survey respondents had never heard of SSM, despite it being free and already operating in the city. That is the problem we set out to solve. To understand the problem fully, we pulled from peer-reviewed literature, the ABS, AIHW data, and industry reports. We organized our findings through a PESTEL analysis, a SWOT, and a competitor analysis. The literature confirmed that barriers to healthcare access exist at three levels: personal, provider, and system. On the personal level, stigma and fear of judgment are significant. People avoid seeking help not because the service is bad, but because they do not believe it is meant for them. The PESTEL analysis told us the external environment actually supports SSM. There is federal and ASHH funding, growing public awareness, and political attention on homelessness. But the cost of living crisis is simultaneously expanding demand and squeezing charitable donations. And limited smartphone access makes digital-only approaches largely ineffective for this population. The SWOT confirmed SSM's service model is strong. Its core weakness is presence, not quality. The dominant remaining barrier is community visibility, not service capability. And that is exactly where our solutions focus. To complement the literature, we ran a 20-respondent online survey with community members, social service workers, and healthcare professionals. The results were striking. 90% had never heard of SSM. 75% rated current services as ineffective at reaching homeless people. And 85% rated the pop-up concept as effective for improving awareness. A quick ethical note. We did not survey people currently experiencing homelessness directly, given the risk of re-traumatization without proper duty of care protocols. Instead, we triangulated their perspective through frontline workers and academic literature, an approach validated by Paradis Gagny and colleagues at 2023. The survey also identified where and how to reach people. Outreach workers were the most trusted channel, cited by 55% of respondents. Preferred locations were soup kitchens, food banks, CBD parks, and libraries. Together, these findings pointed us firmly upstream, towards awareness and first contact, before clinical delivery even begins. We built three synthesis tools to deepen our understanding. The first is an empathy map, drawn from our survey data and frontline worker insights. The key pattern it revealed: shame and fear are the dominant forces stopping people from self-identifying or seeking help. Marcus, our composite persona, hears from peers that services are unreliable. He sees mainstream clinics as intimidating, he feels invisible. He avoids seeking help until help becomes critical. Awareness alone cannot overcome that, which is why trust building has to be built into the solution from the very first contact point. This is Marcus. He is 42, has been sleeping rough in Melbourne CBD for 3 years after losing his job to the cost of living crisis. He has limited smartphone access. He relies entirely on word of mouth for information. His defining quote: "I don't know there was a free doctor nearby. Nobody told me. I only found out by accident." Marcus is not unusual. He represents a population that is not hard to reach because they are unwilling. They are hard to reach because the information simply never got to them. That is a solvable problem, and it is exactly what our solutions address. Our customer journey map traces Marcus' experience from the moment he walks past an SSM location, unaware, true to follow-up care. The critical finding: the biggest drop-off happens at the awareness and contact stages, before he ever reaches the service. By the time Marcus arrives at a pop-up, he is actually willing to engage. The system is not failing him at the clinical delivery stage. It is failing him much earlier. This confirms where our design opportunity sits, upstream, at visibility and first contact, not at the point of care itself. Everything we found points to the same conclusion. The barrier is not the service, it is visibility and trust. People do not know SSM exists, and even when they do, fear and stigma stops them from showing up. 90% of our respondents had never heard of SSM. 75% rated current services as ineffective at reaching homeless people. And the literature is consistent. Awareness is the number one access barrier for this population. But here is the nuance that shaped our entire solution design. Awareness alone is not enough. Knowing SSM exists does not mean someone will walk up. You also need trust, physical accessibility, and relational support. Without awareness, trust cannot develop. Without trust, referrals cannot occur. Without referrals, continuity of care cannot begin. Awareness is the precondition for everything else. And the opportunity sits upstream, at the awareness and contact stages, not at clinical delivery. The hidden homeless, such as DV survivors, people in unstable housing, or people afraid to seek help, they often don't even recognize SSM services are available to them. So our how might we statement became, how might SSM improve their visibility amongst the homeless so that they are well informed of the free mobile healthcare service? With a clear problem, we move into structured ideation. We use the brainwriting approach across 5 rounds, where ideas were written silently and passed between team members to build on, a method shown to reduce groupthink and ensure equal contribution. We generated over 50 distinct ideas covering physical presence, technology, advertising, peer trust, and workforce. A key insight that shaped our thinking was broadening the definition of who we were designing for, not just visible rough sleepers, but hidden homeless. From those 50 ideas, we used 3 convergence tools to narrow down: a few concept selection matrix with 6 weighted criteria, an impact effort matrix, and a desirability, viability, and feasibility check. The winner across all 3 tools was the SSM pop-up activation, with a view score of 35, the highest of any concept. Advertising was retained as a phase 1 quick win. Peer accompaniment was kept as the trust building layer embedded within the pop-up. These 3 solutions do not work in isolation, they work as a system. Advertising opens the doors, the pop-up creates the real encounter, and peer accompaniment keeps the relationship going. I will now hand over to Hong Tai, who will walk you through each of our 3 solutions in detail.
So let's start with the winner. The SSM pop-up is a visible health presence set up in everyday public spaces. The big thing here is that people don't have to label themselves as homeless to walk up. That matter a lot for hidden homeless. It builds awareness, it builds trust, and it connects people straight to SSM. It ranks first because it was the only idea that scores well across all 3 of our checks. Here's how it runs. First, we pick busy spots like parks, libraries, and shopping centers. Then we set up a branded booth with QR stands and privacy screens. We keep it warm, non-clinical, no question asked, so that people feel safe coming over. From there, the team give health info and link people to SSM. And we don't stop there. We follow up with simple text reminders and keep that care going. Our second idea is the targeted awareness campaign. This is the social media ads, community posters, and the public info materials. It's quick to launch, low effort, and reaches a lot of people fast. The honest trade-off is that advertising can raise awareness, but on its own, it can't build trust or connect someone to care. So it works best alongside the pop-up and our third idea. How did we build it? We start with a rough hand-drawn poster and tested them in the team to make sure the message was clear. Then we refined the wording to reach people who don't see themselves as homeless. We widen it again to include people facing domestic violence and housing stress. And finally, we build a polished digital poster and would place it in libraries, shelters, and transit hubs around Melbourne. Our third idea is peer accompaniment. These are peer navigators recruited from community itself. They come to pop up walk they come to pop up, walk alongside people to their appointment and stay in touch in between. It's a relational role, not a clinical one, because they live it. They break down the fear and stigma that stop people reaching out. It ranked second and was our strongest idea on community trust. Here's how it works in three steps. First, we recruit and train the navigators with trauma-informed training, a clear role, and fair pay. And we would love if they are volunteers. Second, we bring them into the pop-up to start conversation and makes it easier for people to engage. And third, they stay alongside clients at appointment and between visits. And after each activation, we run a debrief to look after their well-being too. We want this to be sustainable, not just effective. So how do these three stack up? First, we ran them through the DVF test, which is the desirability, variability, and feasibility. Advertising is wearable and feasible, but on its own, it isn't really desirable to people we're serving. Peer accompaniment is desirable and wearable, but only partly feasible right now because of the resourcing. The SSM pops up is the only one that ticks all the three boxes. Then we look at the impact versus effort, and that tells us the order to roll them out. Advertising is a quick win, so it runs first. The pop-up and peers accompaniment are high effort, so they come after as our longer term plays. So here's what we recommend in three phases. First, week 1 to 4 launch awareness campaign to get SSM on people radar. Second, week 4 to 12, run an 8-week pop-up trial at Melbourne site. And third, month 3 to 6, look at the results, scale to more locations, and set up peers accompaniment properly with funding and training. The three idea works together. Advertising open the doors, the pop-up create real contact, and peer accompaniment keeps that relationship going. So what would all of these actually achieve? Well, we're aiming for three things. First, more awareness, so people know SSM exists, and that's it for them. Second, stronger engagement, meaning more people actually come up and accept support. And three, care built on trust, so it become an ongoing relationship, not just a one-off. And each one is something we can measure on and track over time. That's our plan for Street Side Medics. Thank you.